All right, let's continue our discussion on the 68-year-old man. What is the answer to our question? Is to start intravenous alteplase. Now, you can also substitute this word with medication with TNK, which is becoming used more than alteplase. Let's talk about this. For patients presenting within 4.5 hours of symptom onset and disabling ischemic stroke, no contraindications. And we'll go through the contraindications. The first line therapy should be IV TPA or TNK. The blood pressure should be less than 185 over 110 prior to administration. We'll work through the reasons not to give it, but we're going to try to figure out ways that we should give it. Ischemic stroke. Ischemic stroke is defined by presence of cerebral infarction on imaging. Anticoagulation should be appropriate, and we'll talk about this. CHA2DS2-VAS pending valve status, we'll talk about this. And then this is a tool I'd like you to go through with your patients. It's WW Spark tool. And what it does is it gives you answer questions, and from this you get the CHA2DS2-VAS score and the HAS-BLOOD score, and it helps you determine what's going to be the best agent for you to use. And you can sit down there, and I would actually, as an outpatient physician, I would keep this, or outpatient provider, I would keep this information and then store it in the patient's file and show that you've had a meaningful discussion. Now, remember is admission to the stroke unit is associated with a reduction in mortality at 1 year, and benefits persist up to 10 years. Ischemic stroke, extracranial internal carotid artery arthrosclerosis has the highest risk of recurrent strokes within the first 2 weeks, where you have a monocular vision loss and presence of carotid bruit or on the ipsilateral side. Recurrent risk is highest when greater than 70% stenosis. Carotid ultrasound is a useful tool, but they is a first assessment. However, they still may require CT and or MRI angiographic before a stent placement can be done. Intracranial arthrosclerosis has a high lifelong stroke risk and recurrent stroke risk, and can use a transcranial Doppler ultrasound for accelerated velocities concerning for significant stenosis. All right, folks, back onto the discussion of our ischemic strokes. Now we're going to talk about lacunar strokes. Well, what's lacunar? It refers to a small pit or pond-like areas. These are small strokes caused by blockage of tiny vessels in the brain, specifically in the small, deep penetrating 15 millimeter diameter, and occur in areas in the basal ganglia, internal capsule, and thalamus. While they often don't cause notable symptoms, they can contribute to the cognitive decline or dementia in numerous or located in critical areas of the brain. Lacunar infarcts, here we talked, is coming less than 1.5 centimeters, 15 millimeters in size, and come from occlusion of small perforated arteries from the large intracranial vessels. Typically come with either only motor symptoms or sensory findings. Hypertension is the primary risk factor, causing changes to the origin of the arteries. What is a diffusion MRI? And the reason why we're discussing this is you'll see this terminology, and I just want to make sure you understand what it is. Remember, you have to have these little pieces of knowledge to build the big base. And sometimes we'll just gloss through and say, oh, I know what a diffusion MRI is. But let's know what the details of it are. Diffusion MRI, it's an MRI that shows the tissue changes based off of water density. It's performed to assess the microscopic movement of water molecules within the biological tissues, providing critical information about the tissue microstructure and pathology. It's more sensitive to early changes after a stroke than a traditional MRI. So we're trying to get these early changes with the diffusion MRI. Aspect score. This is the important thing, okay? Aspects, and it's the Alberta Stroke Program early CT score, determines the middle cerebral artery stroke severity using CT data. It estimates the infarct size and is used to guide acute treatment decisions, including eligibility, should we give reperfusion or not? Or should we do mechanical thrombectomy or nothing at all? And it goes everything from 0 to 10. 10, there's no ischemic changes to 0, there's extensive ischemic changes throughout the MCA territory. You take 1 point off for any evidence of early ischemia and a change. So 10, you start off with a 10 and you get down to 0. So you take off 1 point for any evidence of early ischemic changes for each area defined of the MCA territory. Decreases debility when they're less than or equal to scores of 7. So less than or equal to scores of 7, you have increased debility. Scores of 8 to 10 have better outcomes. So what does that mean? Is that areas where we have this massive ischemia, if we do reperfusion, there's a risk that the patient can bleed and that our medications can cause harm. Remember, first do no harm. Now let's talk about the modified Rankin score. This is so important in strokes, and let's explain why. Modified Rankin is used to measure the degree of disability or dependence in daily activities of people who have suffered a stroke and/or other neurological disability. And why is this important? This tells us, the whole purpose of us taking care of patients with stroke is to avoid death, of course, but also disability. Can you imagine for the rest of your life is having to lay in a nursing home bed and having to be flipped every 2 hours by nursing home staff and having your butt wiped? These are things, first of all, look at what happens is this person is no longer a productive member of society. And they're no longer able to contribute their job. Maybe they're a teacher, police officer, fireman, whatever they are in their life, they're not able to continue this. And they're in bed and look at all the resources that has to be used. I know this sounds like money and a money problem, but it's a people problem. And just think of all these resources that can be contribute to society. So modified Rankin score is 0, no symptoms. 1, no significant disability and able to carry out all usual activities despite some symptoms. 2, slightly disabled, able to look after their own affairs without assistance, but unable to carry out all previous activities. 3, moderate disability, requires some help, but able to walk unassisted. 4, this is where we start getting moderately severely disabled, unable to tend to own body needs, basic needs without assistance, and unable to walk unassisted. Can you imagine this for the rest of your life or for a long period of time? Because you're going to have assistance in carrying out your basic activities of daily living. 5, severely disabled, requires constant nursing care and attention, bedridden and incontinent. And then 6 is dead. So the goal is to reduce the modified Rankin score, is to take somebody and first of all, avoid death, avoid severe disability, and get them where they're able to have no symptoms or minimal symptoms and able to carry on their lives. Let's talk about treatment options for ischemic stroke. Medical management or IV TPA or TNK, they help break the clot. Now these were first approved, we're going to say TPA was first approved in 1996, and this is the problem. Only 8%, and this is why this is tested heavy on boards, only 8% of ischemic patients are eligible. Most arrive outside the time window. It's a narrow time window, and the risk of cerebral and ischemic hemorrhage gets worse if we do not get in with this window. Now, there's been studies, and someday this may extend out, but so far right now, we're going to keep it with the windows, and we're going to discuss what the specific criteria are. Only 13 to 50%, so once they get these medications, only 13 to 50% reperfusion of large vessel occlusions. That's why we do other things, which is considered, which is the endovascular clot removal. The mechanism disrupts or removing the clot using standard endovascular approaches. This is becoming more popular. There's becoming more devices. There's more devices all the time. The goals of treatment here again is to reduce debility. You want to save, and we're going to talk about this term penumbra. So this is the salvable tissue. So let's talk about this. Is we have the dead tissue, we have the penumbra, and then we have the good tissue. What we're trying to do is turn the penumbra towards the good tissue. Everything we're doing is trying to save as much brain tissue and neurons we possibly can. Just think of it as your neighborhood. You have your good neighbors over here and your bad neighbors, and then you have your middle neighbors. And we're trying to get the middle neighbors over to be good neighbors, so you have a better neighborhood. Now let's get to the studies of tenecteplase versus alteplase. The rate of symptomatic intracranial hemorrhage was lower in tenecteplase. This was a big study, and there was no difference in mortality. So this is where first would be alteplase, was heavily used. Now we're switching over to see tenecteplase, and you're going to use the terms TNK for that. Tenecteplase is FDA-approved medication specifically, this has been around for a while, for patients with ST elevation acute MIs. This is back in 2020. It was off-label and used for PEs, ischemic strokes, and then this change occurred with this large study where back in 2023, where we found that tenecteplase was good, is just as good as alteplase, and it actually had intracranial, reduced the symptomatic intracranial hemorrhage, was lower. So this was an important change, and you're probably seeing it in your institutions. Benefits of stroke thrombectomy extends to patients with large core infarcts, okay? This is where we started to have these changes, a shift towards lower disability at 90 days with thrombectomy. That's where they go in through a catheter up into the brain. When you think about it, it's crazy. And there's new devices, all sorts of devices are being tested. And the devices used now, probably in the future, we won't even be using. We'll have something even more sophisticated. Versus medical management alone. 30% with functional independence in thrombectomy arm versus 11.6% in the medical arm. And the reason why is that these medications, the tenecteplase or the TKA, they only get certain parts. They get, at best, is 50%. And then we can specifically get to the lesion with the thrombectomy and in theory remove that lesion and improve our blood flow. Intracranial hemorrhage are more common in the thrombectomy arm, but they are asymptomatic. And it could be a huge difference. It's 49% or 70%, but asymptomatic provides strong evidence to support extending stroke thrombectomy to patients with large core infarcts. 30 to 40% of ischemic strokes are large vessels. Internal carotid artery has about a 53% mortality. Middle cerebral artery has a 27% mortality. And the basal artery, this is the big one. This has an 80 to 90% mortality rate. And I want you to start thinking as the brain as real estate. And I want you to think as the arteries as roadways. And we're trying to open up the roadways so you can get to your real estate. Now, what's a cryptogenic stroke? On evaluation, there's no cardioembolic source or large vessel atherosclerosis. This is noted. So basically, we don't know why this patient has had a stroke. If the patient is young, consider hypercoagulable or autoimmune disorder. What is going on? They're having an unknown clotting disorder. If otherwise, unexplained stroke cause. So we're trying to figure out what the cause can be. 25% may have a paroxysmal atrial fibrillation or prolonged cardiac monitoring is advised. This is where you would wear the Holter monitor, a loop recorder, these kind of things to find out why this person had a stroke and so we can avoid strokes in the future. Percutaneous closure, or PFO, is shown to have a reduction in risk of ischemic stroke. The PFO is a patent foramen ovale. This is seen in the bubble study in echoes. That's why when someone comes in for a stroke, they get a special type of echo. It's called the bubble study, where they put in these they're going to shoot small amounts of fluid in there to see the bubbling between between both sides of the heart. And in the past, closure was not effective for PFO, but they've had better techniques, and this closure has helped improve and reduce the amount of strokes. Management of TIA and minor strokes. Risk of recurrent strokes. So why do we admit people with TIAs or minor strokes? Because we have a risk of recurrent strokes. Stroke risk is highest in the first 2 days after TIA, is going to be 4 to 10%. Hospital admission is recommended for all patients within 72 hours of initial symptoms with the ABCD2 score is greater than or equal to 3. Now, this is a scoring system that you can definitely, there's multiple calculators online that you can pull this up. And when we're doing an admission for a stroke in patient, what are we looking for? We want to get further neuroimaging, including an MRI, a diffusion waist MRI if we can, that's going to be best practice, or a CT angiogram or carotid duplex ultrasound study, or transcranial Doppler ultrasound to detect large vessel occlusive disease. We would get an echo, and we get the preferred would be a bubble study. Question of getting a Holter monitor if we're looking for an arrhythmia that is not being present on our monitoring. getting basic labs, which includes CBC, TTP, electrolytes, creatinine, and to start this workup. So the ABCD2 score, what is this is a scoring system, and it's based off of A equals age greater than equal to 60 years, B equals blood pressure with a systolic blood pressure greater than 140 or diastolic pressure greater than 90, C equals unilateral weakness would be 1 point, speech disturbance is 1 point, duration less than 1 hour or greater than 1 hour, and D is, the second D is going to be diabetes. So you can easily look at the scoring system. If you have greater than or equal to 3, this is when you'd want to get admit the patient and do the workup. The reason why is that we can do is get this patient worked up. Also too is they have a greater risk for having a follow-up stroke and follow-up cardiovascular event, and at that time they'd be inpatients, and we can evaluate if it'd be effective to give them TNK or TPA. Okay, now let's get the proper nomenclature so that when we're talking to our other colleagues, that we don't think that we're crazy. Okay, so we want to order a Holter monitor based off the Dr. Norman Holter, who helped work on discovering the device. This is a Holter top. Holter top. We are not ordering Holter tops for our patients. We're ordering a Holter monitor. Very important. Otherwise, we're going to look more crazy than we are. So management of TIA in minor strokes. Treatment case started in most cases within 24 hours. Initial therapy is aspirin or clopidogrel. The dosing would be 75 milligrams daily on the clopidogrel as a monotherapy or in combination with aspirin or extended release diphenhydramine. Oral anticoagulation for atrial fibrillation. And Spark tool, I recommend you really go to this website and work through it. It can really help you make decisions on oral anticoagulation. Every major oral anticoagulation is available. Carotid endarterectomy is indicated for stenosis 70 to 99%. So remember, if it's 100%, there's nothing they can do. 100%, there's nothing they can do, but 70 to 99% you can. Less than 70% is not recommended. No benefit in stenting a bypass of a completely occluded intracranial vessel or extracranial intracranial compared to medical therapy. So if it's completely occluded, stenting that is not going to help. Carotid stenting with an embolic protective source is an alternative, particularly in patients with a high surgical risk or contralateral occlusion or severe coronary disease or recent stroke. In patients less than 70 years old, aspirin plus clopidogrel for 1 to 2 months after stenting, followed by aspirin indefinitely. Major risk factor modifications is what we need to do. BP control, statins, glucose control, smoking cessation is very big, getting exercise 30 to 60 minutes, 3 to 4 times daily, and you could say every day if possible, avoid excess use of alcohol. Here we go is another example of the ABCD2 scoring system in a TIA. We briefly went through it, but basically you can walk through the scoring system. It's very easy to do. Scores 3 or higher, so 3 or 4 to higher, so you have this increased risk of a further follow-up stroke, and that's why we want to get them inpatient. Very easy to use, and it's multiple scoring systems or multiple calculators are available online where you can easily do this. And let's talk briefly on localization of cerebral lesions in a stroke. And why we do this is so to help understand the presentation. This is also so that we can correspond with our neurology teammates. Remember, I want you to think this is real estate in the brain. Neurologists are real estate agents of the brain, and they're trying to get what sector of the brain is having an occlusion or a problem. So anterior cerebral artery is going to have the medial cerebral hemisphere, contralateral weakness and sensory changes in the legs greater than the arm, and behavioral changes, sudden urinary incontinence and personality changes, internal carotid artery ipsilateral vision loss, contralateral hemiparesis and sensory loss, hemoptysis hemiplegia. What is hemoptysis hemiplegia? Is a form of vision loss that's characterized by the loss of vision on the same half of the visual fields on both eyes. Same half of visual fields on both eyes. So this side right here, this side right here, aphasia if involved in the dominant hemisphere. That's why neurologists, when they ask people, are they right and left-handed, it helps them determine on if they're having a lesion, where that lesion could be, and what's going involved. If they're having aphasia, it's going to be on the dominant side. where they have the lesion. Middle cerebral artery is the lateral cerebral hemisphere, contralateral hemiplegia and sensory loss. Here we go, hemoptysis, hemiplegia, and aphasia. Branch of the middle cerebral artery can have contralateral hemiplegia without sensory or sensory loss without hemiplegia. Locations of cerebral lesions in a stroke continued. Posterior cerebral, this is one we kind of fear right here. Posterior circulation. I just want you to know is the posterior portion of the brain where the basilar is, it doesn't show up really well on a CT imaging, and that's where you probably have to get an MRI, and we'll talk about what's called a Hintz exam. Posterior cerebral artery is the inferior cerebral hemisphere. It's the ipsilateral 2/3 nerve, so of the nerve, and contralateral hemiplegia would be Weber syndrome. So Weber syndrome is going to have ipsilateral 3rd nerve and contralateral hemiplegia. Going to have ipsilateral 3rd nerve and contralateral ataxia. That's going to be Claude syndrome. In hemoptysis, hemiplegia, cortical blindness if bilateral involvement. Basilar artery, this is very important right here. This is, remember, it says high mortality, not seen well on the CT imaging. That's where MRI is suggested. That's where you would do a Hintz exam to say, do I need to get an MRI? The basilar artery is a brainstem, pontine medullary junction, bilateral sensory and motor signs, cranial nerve involvement in 5, 6, and 7. Cerebral signs, diminished pain and thermal sense over half the body with Horner syndrome. The vertebral artery, it's a brainstem. This is an on-off switch for the brain. You can have loss of consciousness with this. You have the lateral medulla. You can have vertigo, ataxia, nystagmus, Horner syndrome, diminished pain and thermal sense over half the body. Posterior inferior cerebral artery, lateral medulla, ipsilateral facial sensory loss, contralateral body sensory loss, vertigo, ataxia, dysarthria, dyspopia, both parts of the brain.